medication, in addition to other medical products, medications for the treatment of diabetes. And we're lucky that few months down the road after that, we also received the approval for chronic weight management. So tirzepatide has been indicated as an adjunct to the reduced calorie diet and increased physical activity for weight management, including weight loss and weight maintenance in adults with an initial BMI of 30 or more than 27 less than 30, in the presence of at least one weight-related comorbid conditions like the hypertension, dyslipidemia, obstructive sleep apnea, cardiovascular disease, prediabetes, or type 2 diabetes. These are the safety contact information in case if you have patients or you have prescribed tirzepatide to your patient and you have noticed any adverse events or any safety concerns, please report them directly to this email, Saudi_pharmacovigilance@lilly.com. They also have mobile phone and a landline with extension. And also you can email for Eli Lilly products on Saudi_medi info queries at elililly@lilly.com. So please make sure that you are reporting any adverse events or safety concerns you have with your patients. For healthcare professionals also, you can also always join the Eli Lilly Healthcare Professional Network, which includes Eli Lilly Medical Database, Library, CME Hours, as well as some expert videos from international speakers. So let's begin our talk with diabetes, and after that we will move toward obesity, and I'll finish my talk by providing some time for the questions which you can write in the chat box. So if we start thinking about diabetes and we look at how are we doing in Saudi Arabia in terms of our diabetic patients throughout the world, we know that the majority, or let's say not majority, a high percentage of patients, at least 50% around it, those patients really do not achieve the glycemic control despite the available therapies. And if we look at the percentage of patients not achieving this glycemic control in Europe or USA, we are talking about anywhere between 44 to 49%, while it's around reaching up to 70% locally. So what does that tell you? That tells you that at least when you see patients, 7 of the 10 patients you are seeing with diabetes, unfortunately, they are not achieving the glycemic control. And just, I want you to keep that in mind because it's extremely important to achieve a glycemic control. And the other thing is that the majority of the patients we do see in our country with type 2 diabetes, they have excess weight. So the prevalence of diabetes is really high in our population. And majority of our population also will have obesity. So this was from a cross-sectional study done at King Fahd Medical City, in King Fahd Armed Hospital, where they found that at least 8 out of 10 patients with diabetes will have either obesity or being overweight. So if you're seeing 10 patients of diabetes in your clinic, 8 of them will be either obese or overweight. This is according to the local data. And according to the guidelines or the guidance we have from the ADA or the ESD, it's clearly showing that in patients with type 2 diabetes, a higher magnitude of weight loss leads to a better outcome. This is very clear and has been proven. So 5 to 10% in patients with diabetes is going to yield good metabolic improvement. 10 to 15% or more may have a disease-modifying effect and might lead to remission. So people with type 2 diabetes can especially benefit from an early aggressive therapy, and the damage caused by type 2 diabetes can present present early compared to ongoing lifelong benefits of early aggressive treatment. And I'm going to show you why early intervention is crucial in our diabetic patients. So if we look at this landmark study, the UKPDS trial, which result has been presented throughout the last 3 decades, we can see that the early glycemic control, so those patients who were managed early, those who were patients who were picked up early at the time of diagnosis, and they were managed earlier. So that earlier management actually has translated into better outcome 20 years down the road. So for those patients, this is what we call a legacy effect. And basically lowering and 1%, like lowering the A1C at 1% at the time of diagnosis will have a greater clinical impact than delayed control. So think about this when you are seeing patients with diabetes and you're saying, you know what, you only have an A1C of 6.5 to 7, you're doing fine, just go and do some diet and exercise. Think about this, what is going to happen to your patients 20 years down the road. So the earlier we intervene, the better we can help them, because it's very clear, as you can see it from this slide, looking at those who had a higher A1C at the time of diagnosis versus an earlier control, it was very clear that those with early control actually had lower mortality and lower risk of myocardial infarction versus those who had a higher A1C and they were left alone just with diet and exercise. And it's very clear that the lower HbA1c early after diagnosis was associated with a lower risk of micro and macrovascular complication. So on this screen, so this actually represents the hazard ratio for the microvascular event. And you can see that 1 year post-diagnosis with diabetes, if their A1C is between 6.5 to 7, their hazard ratio for microvascular complication or events, it's around 1.2. And that almost doubles if at 1 year after diagnosis, their A1C remains at 9. Think about those patients you are seeing in your clinic 20 years down the road, and they are presenting with diabetic neuropathy, retinopathy, nephropathy. In my clinic today, I have seen at least a bunch of those patients. And really, I wish if the time goes back, really, if I'm able to help those patients, keep them here instead of reaching that level of A1C 1 year down the diagnosis, because it's very clear if their A1C 1 year down the diagnosis is more than 9%, their hazard ratio is much higher for the microvascular complication. And the same applies for macrovascular complication as well on the right side of the screen, as you can see. So let's talk about, our patients with type 2 diabetes. This is Noura. She is diagnosed with type 2 diabetes. She has not reached her glycemic target. She's on metformin alone. She continues to struggle with her weight despite her efforts with diet and exercise. So she's not satisfied with her hemoglobin A1C. She is concerned about her weight. And as we said, that at least in our population, we are seeing 8 out of 10 patients to be either overweight or obese in type 2 diabetic population in Saudi Arabia. So let's dig into a little bit of this pathophysiology. Before we do that, the tirzepatide, what is tirzepatide? Is a single molecule that is designed to activate, as you can see on the right side of the screen, both receptors, the GLP-1 receptors and GIP receptors. The tirzepatide is highly selective for both of those receptors and has a very high affinity toward GIP. And the activity of tirzepatide is on GIP is similar to the naive, that of naive GIP, like in principle GLP, it's a little bit lower compared to that of native GLP, not naive, I'm sorry, it's native GLP. So really, it's a single molecule activating or working on 2 receptors. And its half-life is made in a way that really there's no dose adjustment is needed or required for patients with renal impairment or hepatic impairment, including those with end-stage renal disease. How does it work? In the clinical studies, it has clearly shown that tirzepatide increases the fat oxidation and the feeling of satiety and fullness. It will help our patients to decrease the food cravings, the tendency to overeat, and the hunger and the reactivity to environmental food cues اللي هنسميها باللغة العربية ضجيج الأكل. The tirzepatide lowers the body weight and the body fat mass further. This reduction in the total fat mass will be accompanied by reduction in the visceral fat, اللي هي الدهون الحشوية. So it works by reducing the energy intake and appetite, and also it increases the fat oxidation and feeling of satiety, improve the sleep satiety, and so on. So let's talk about the studies that has been done in tirzepatide in patients with type 2 diabetes. So we have seen that patient Noura, who's been struggling with diabetes, and she's on metformin, and she's really not happy with her weight, neither with her A1C. So in this study, basically, SURPASS-2, it was a randomized, open-label, active control, multi-center, multinational trial that ran for 40 weeks. And they compared the tirzepatide 5, 10, or 15 milligram versus the semaglutide on the background of patients who were only on metformin. As you can see, that those patients had diabetes that not controlled, so their A1C at baseline was 8%, 8.3%, and they had diabetes for around 8 years. So really you wanted to see, when you see patients with type 2 diabetes, and they have a very long duration of diabetes, let's say they've been diagnosed with diabetes for the last 8 years, and you're asking yourself, can tirzepatide work for this patient or not? Here's the answer. So you can see that in this group of patients, they had diabetes for 8 years, had an A1C of 8.3 with a BMI of 34, and they were randomized either to receive tirzepatide 5, 10, or 15 versus the semaglutide 1 milligram. And what we have seen in this landmark trial, that tirzepatide actually provided an excellent HbA1c reduction, with actually superior HbA1c reduction, even with the dose of 5 milligrams. So we can actually say that all 3 doses of tirzepatide, which is 5, 10, and 15, actually led to a superior hemoglobin A1c reduction versus the semaglutide 1 milligram. So you can see in patients who are on semaglutide, the best they can achieve is 1.9% hemoglobin A1c reduction, versus the tirzepatide. You can see it in this, the blue color. This was the 5 milligram, which included around 400 patients. The hemoglobin A1C reduction was around 2.1%. And this was the lowest dose of tirzepatide, actually, which provided a better HbA1c reduction versus the higher dose semaglutide in patients with type 2 diabetes. And if you go beyond the 5 milligram, look at the 10 or the 15 milligram, you can see the hemoglobin A1C reduction is actually better, exceeding 2%. So this is why at the beginning I said, this is an exciting era we're living in. Since when we have medications actually that can exceed the hemoglobin A1C reduction of more than 2%. And in this, you can see that the hemoglobin A1C reduction actually sustained compared with semaglutide. You can see those who are on 15 milligrams actually reaching up to 5.8% of hemoglobin A1C. So the tirzepatide, we can say, at least delivered a significant hemoglobin A1C reduction over 40 weeks, with reduction observed as early as week 4. So you can see the separation of the curves. So these were the colorful tirzepatide curve versus the circle dotted semaglutide. You can see the separation happening as early as week 4. And this is huge for our patients with type 2 diabetes. And if you look at the percentage of patients who can achieve a hemoglobin A1C goal of less than 6.5%, I want you to think about the slide I presented at the beginning and think about what's the percentage of control in our patients with type 2 diabetes. If you remember, I said 70% almost in our patient with type 2 diabetes, they are not controlled. Now, let's switch and look at this medication and look at what's the percentage of patients who are achieving an hemoglobin A1C that's less than 6.5% down the road. So we're talking 40 weeks down the road. So look at this. For less than 7%, we are talking 92% of patients. 92% of patients achieving an A1C of less than 7%. 87% of patients achieving an A1C of less than 6.5%. This is why we're living in an exciting era. We haven't had such medication or molecule that can really help our patients with diabetes to achieve this level of glycemic control in the past. So remember those 69% or the 70% of patients we are seeing that we are not controlled in our local population. And remember that we do have a molecule that can actually help to achieve that control in more than 90% of our patients. And look at the other doses. If we look at, this is 15 milligrams, okay? So if you look at the 5 milligram, which is the lower dose, we're talking about 86% of patients without even need to reach the 15 milligram. 86% of patients achieved an A1C of less than 7%. 74% is still high percentage that what you are seeing versus what you are seeing in the clinic. And again, all those 3 doses, you can see that percentage in terms of percent control were higher than the semaglutide of 1 milligram, which almost achieved 66 to 81% control. And if we look at, if you really want to divide those group of patients who actually had a baseline hemoglobin A1C that is less than 8.5 versus those who had an hemoglobin A1C of more than 8.5, you can see that every dose of tirzepatide effectively lowered the hemoglobin A1C, whether baseline value was above or below the 8.5%, as you can see on the screen. So on the right side of the screen, this were the group of patients who had an A1C of more than 8.5. And this you can see in tirzepatide 15 milligram, they achieved a 3.3% reduction of hemoglobin A1C. Remember, what's the best achievement of hemoglobin A1C we can get with our patient? The maximum we can get, we've heard in the last few years, is really the 1 or 1.5. We have exceeded that with tirzepatide. We are talking about 3.3% reduction in hemoglobin A1C when their hemoglobin A1C was more than 8.5. And it reaches up to 2% reduction if the hemoglobin A1C was less than 8.5. Again, this is a molecule that is was studied in 3 doses in this SURPASS trial, and these results were for 15. So if you look at the 5 milligram, let's talk about the 5 milligram of tirzepatide. If the hemoglobin A1C was more than 8.5%, the 5 milligram of tirzepatide was able to achieve 2.9% hemoglobin A1C reduction. That's amazing. And if the hemoglobin A1C was less than 8.5, and we know the lower the hemoglobin A1C, it will be more difficult to get a better control. It was around 1.6% reduction in those group of patients. So amazingly controlled in this group of patients. And if we look at the weight reduction, I know this was a diabetes trial in patients with type 2 diabetes who were on metformin that were not well controlled. Like if you look at the percentage of weight reduction, beautifully, as you can see, that an average, if they achieved, those who were randomized to the 15 milligram, they achieved at least 13% weight reduction versus 11% in those on 10 milligram versus 8%, 8.5% for those who were on the 5 milligram. And comparing that to the semaglutide 1, which also achieved a weight reduction, but was around 6.2% only. So tirzepatide 15 milligram delivered double the weight loss versus the semaglutide 1. So we're talking about 12.4 kilograms versus the 6.2 kilograms that was seen in this trial. This was the same thing, as you can see, the sustainability of weight loss and the separation of the curves that happened, that we have seen it with the hemoglobin A1C reduction. We are seeing it also as well with the weight reduction as well from week 4. Now, what we see is tirzepatide actually delivers significant weight reduction from baseline over 40 weeks, with reduction observed as early as week 4 that did not plateau. So the patients continued to lose weight in this trial. And if we were, and this trial was actually for diabetic patient, the primary objective was really to look into the hemoglobin A1C reduction, comparing it versus the semaglutide 1 milligram. If you look at the percentage of weight loss, I remember 7 years ago, we were only talking about the 5% of weight loss. Now we have expanded that. We have 10% and we have 15%. Let's look at the right side of the screen. We are talking about 40% of patients who were on tirzepatide 15 milligram, 40%. So 4 out of 10 patients you are seeing in your clinic achieving a 40%, achieving a more than 15% of weight loss. And on the left side, if you look at the clinical significant weight loss, which is 5%, we're talking about 86% of patients achieving the clinically significant weight loss, which was 86% in patients who were randomized to tirzepatide 15. And if we look at the tirzepatide 5 milligram, for example, we're talking about 70% of patients reaching or achieving the more than 5% weight loss in this group. And again, you can also see the 10%, the percentages of patients who achieve the 10% weight loss, which was almost 65% in those who were randomized to tirzepatide 15 milligram. And very interestingly, when you see the percentages of weight loss, either 5 or 10 or 15, and you compare the lowest dose of tirzepatide, we're talking about 5 milligram versus the of tirzepatide versus 1 milligram of semaglutide, you can see that tirzepatide has succeeded in achieving a better A1C, even with the lower dose, a better A1C. We're talking about the better A1C, more weight loss, percentage weight loss, and more weight loss in different weight loss categories. What about the adverse events of tirzepatide and semaglutide that was reported in this trial, which was expected that at least 17 to 19% of patients actually reported nausea, 13% reported 13% to 16% reported vomiting, and around 5 to 8% reporting dyspepsia and decreased appetite. So it's a part of how the medication works. And one thing noticeable, you might see that sometimes patients report a higher percentage of some of the GI upset in the 10 milligram, but that doesn't mean it's 10 milligram is worse than the 15 milligram. Those reporting of the adverse effects usually happen when the medication doses increases and usually subsides when the patient continue the actual advice that I'm going to give you to give it to your patients. At the end, most of those side effects or the adverse effects usually subside if they continue to follow what was given to them in terms of lifestyle. Shifting gears now toward obesity. So obesity is a global epidemic. Many world organizations, including now the WHO a couple months ago, the American Medical Association, the NIH, have defined obesity as a chronic disease, emphasizing the need for strategies at individual and societal levels. So what is obesity? Remember, obesity is like 3 things I want you to remember. It's a chronic, progressive, and relapsing. Chronic, progressive, and relapsing. Obesity is chronic, progressive, and relapsing, and multifactorial disease. influenced by many factors, which you can see on your screen, including epigenetics, genetics, psychological, behavior, social, cultural, environmental. These act as a gateway because obesity then act as a gateway to a variety of other non-communicable disease, which we're going to see later. So all these organizations have endorsed the guidelines and defined obesity as a chronic, progressive, relapsing, and multifactorial disease. Which are these organizations? We can think about the European Association of Study of Obesity, ACE, American Association of Clinical Endocrinology, Obesity Medicine Association, Obesity Canada, European Commission. And as you can see, they all agree that obesity is a disease. So when you look at the slide in front of you and you think about those of your patient with obesity, and you ask your patient and saying, you have an obesity, and I think you really need to eat less and move more, and you are kind of disregarding all these factors that can contribute to the obesity, I think this is something bad we are doing with our patients with obesity. And we really have to change the way we think about this disease and the way we manage obesity. And we really have to think about moving the blame, from the patient to eat less and move more to the biology. So obesity is not a consequence of only excessive eating and lack of willpower. It has many other contributing factors, which I have just shown you. The heritability of obesity, by the way, can approach up to 40 to 70%. So epigenetic, genetic, biological, sociocultural, environmental, and behavioral factors. And I agree, we are seeing more and more of such of obesity because of all these factors that actually complicating our society. And if you look at the prevalence of obesity in our population in Saudi Arabia, you can see that it's almost approaching 22 to 24%. Think about this, and if you think about the diabetes and poorly controlled diabetes, which I showed you at the beginning of my presentation, 69% of patients are poorly controlled. 8 out of those 10 patients with diabetes have either overweight or obesity. And if you look at what's the prevalence of obesity in our adult population, is reaching up to 25%. So these are the numbers really important to remember when you are managing patients with obesity. So reducing weight is associated with improvement of many obesity-related complications. You can see that if the patients are able to lose 5% to 15% of their weight, their dyslipidemia, hypertension will continue to improve. The cardiovascular risk reduction needs to be at least between 15 to 20%. Prevention of type 2 diabetes can be anywhere between 5 to 12%. The remission, they have to lose weight at least more than 15%. The patients with polycystic ovarian who have obesity, to help them with their polycystic ovarian and weight loss, they need to lose at least more than 15% of their weight. So what's clear from here that at least 5% weight loss is needed for metabolic control, and the greater percentage of weight loss, which can reach up to 20 or 25%, is needed for something like obstructive sleep apnea and so on. So let's talk about SURMOUNT-1, which is basically a landmark trial, which basically included patients with obesity. So here we are shifting gears toward patients with obesity. So we talked about the diabetes. We talked how good is this molecule in controlling patients with diabetes. We talked about the hemoglobin A1C. Now let's switch gears toward the tirzepatide use in patients with overweight and obesity. The SURMOUNT-1 trial basically included 2,539 patients who had a BMI of more than 30 or a BMI of more than 27 with at least obesity-related complications, which includes hypertension, so on, excluding diabetes. So they did not include diabetic patients, but they included pre-diabetic patients. And what they were looking at in those patients with obesity, they wanted to look at their primary endpoints. They had two primary endpoints. They wanted to look at what's the percentage of change in weight from the baseline to week 72. And what's the percentage of population who can reach more than 5%, more than 10%, more than 15% weight loss. At the same time, they looked at very interesting secondary endpoints, which were, which are, I think, are very important things that we usually face in our daily practice. They look at the patient's lipid levels, which include the triglyceride, the LDL, the non-HDL cholesterol. They looked at the change in waist circumference. They looked at the physical function score. So they gave the patient the survey, which is the SF-36, which was the physical function score. It's a 36-item survey, and they compared it before and after using the tirzepatide. For the sake of time, I'm going to go through some of these endpoints in my presentation tonight. So, as you can see that the patients were randomized to placebo, injectable placebo once weekly, or to tirzepatide into 3 groups, either reaching 5 milligram and they continued on 5 milligram, or 10 milligram and they continued the 10 milligram, and 15 milligram and they continued the 15 milligram. So participants actually lost significantly more body weight with tirzepatide, as you can see on this screen, which you can see there's a separation of the curve that happened as early as week 4 versus the placebo. So those who were actually, those who reached the 15 milligram of tirzepatide, they lost around 22.5%. So we are talking about average 22.5% average weight reduction with tirzepatide 15 milligram at week 72, at 72 weeks versus the placebo. So if you look at those who were randomized to tirzepatide 10, they actually reached 21.45. They actually reached 16% of weight loss at week 72. What else we have seen with those patients in SURMOUNT-1? You can look at the cardiovascular or cardiometabolic parameters. Look at the systolic blood pressure reduced by 7 to 8 millimeter mercury. Diastolic reduced by 4.6 to 5.5. Look at the triglyceride reduced by 25% to 30% in terms of the triglyceride reduction. The HDL is improved by 7 to 8%. How difficult it is to improve the HDL, and that has been shown in by losing weight with that particular percentage, then that particular percentage of weight loss actually has helped patients with to improve their HDL cholesterol, and as well you can see about 5 to 8% reduction in the LDL cholesterol. Again, the most common adverse reactions were the GI in nature, and mostly were mild to moderate in nature, and mainly they occurred during the dose escalation, and they continue to decrease over time. So before we go further, and I know we have 2 hours to go through, I'm going to go through cases while I'm presenting. And you are more than welcome to answer on the chat box what do you think is the appropriate way to go with such patients. So my case 1 is Miss R, who is a 29-year-old woman who works as an operational manager. And really, if we think about, I wanted to name her case. So it's treating obesity is beyond weight loss. So let's hear her story, what exactly happened. She's 29 years old. She presented seeking treatment for obesity after multiple unsuccessful weight loss attempts. So despite repeated periods of severe caloric restrictions combined with exercise, she consistently regained the lost weight. She works as an operational manager, which is a role requiring prolonged walking and standing throughout 8-hour workday period. What she noticed that she has developed progressive bilateral knee pain that is basically affecting both the quality of life as well as her occupational performance. So when we're talking about managing obesity in such case, it's not really about the obesity, it's about the quality of life and the occupational life. So before you see her labs, what do you think is Miss R's biggest daily struggle? Is it really the persistent knee pain? Is it the regain of her weight despite repeated efforts? Is it the falling down in her performance and confidence at work? Is it the worry about developing diabetes? There is no wrong answer. You can just chat. You can just type in your what's your more uh, common thing you can see. I'm gonna give you like 5 seconds. Right. So let's say it's equally divided. We're talking about 30% for each choice. And what we are seeing is not many people actually got the D, which is the worry about developing diabetes, because literally she did not come up worrying about diabetes, but it was equally divided even among you. Even among you, we are seeing that some of you thought about maybe it's because of the knee pain, maybe it's because of the weight regain, maybe it's because of the work performance. I agree with you. There is no basically there is no signal, there is no single right answer here. All right. So for her, the turning point was not the number on the scale. Okay, it was losing weight to help her make her pain free. So really, for me, in her situation was if I'm gonna choose something out of these, A, B, and C are correct. D also is correct, but for me, in the first visit when I saw the patient, is really the C. That she's really not performing well, and if she's not performing well at her work, she's losing confidence, and she's being blamed because she's regaining weight. So I think I'll go with B. So on presentation, her baseline was 93 kilograms. Her BMI was 37. Her hemoglobin A1C was 5.7. She did not know about this. So this was just an evaluation, a 29 years old female that she's coming to seek help for obesity treatment. And she was found to have a hemoglobin A1C of 5.7. LDL was 155 milligram. Triglyceride was 200. Her ALT was 39. And if we look at those baseline or this baseline profile of this patient, I just presented to you the data of SURMOUNT-1. And think about how can this particular medication, does she fit for to go on the tirzepatide or not? Of course she does. So for me, the primary disease requiring treatment in this patient, yes, it can be prediabetes. Yes, it can be dyslipidemia, but for me, it's all of them actually obesity, which is leading to all of them. So what was the treatment plan for this patient? So what did we do? So if we think about it, we have a young patient. She's fairly young. She's 29 years old. The only thing she has is really the obesity. And now she's presenting with bilateral knee pain. When we did the labs, we found she has prediabetes. She has dyslipidemia. She might have metabolic associated liver disease because of elevated LFTs, although we did not have an ultrasound presentation. She does have a functional impairment due to the knee pain, and she does have a reduced work productivity. And if there is one thing we can do to help with this patient is really to help her lose weight. And that is not going to happen by only advising her to do a diet and exercise, which she actually did a couple of times and she regained the weight back. So what we did with her, we started her on tirzepatide, 2.5 milligram weekly for 4 weeks, and then we escalated the dose to 5 milligram. And then we continued to follow her every 6 to 8 weeks. One very important thing, which I usually do for every single patient with obesity, they have to sit down with a clinical dietitian. They have to get the support in terms of the diet. It really depends on the patients. Some patients are fast learners, so they might need 1 or 2 visits. Some patients might need more closer support. They feel more comfortable talking with the clinical dietitian, at least every week or every month. Somebody is really managing or following them closely. And my clinical dietitians, I'm blessed to have great and excellent clinical dietitians where I work. They also advise my patients about the resistance training program based on what do they see on their in-body measurements. So continuing that, we started with a weight of 93 kilograms. 6 weeks down the road, she was 85. She had mild nausea, but early satiety. She was excellently adherent to her exercise program. She was doing resistance training 3 to 4 times a week, which is great. So when I see this with my patient, I keep saying, like, you are an excellent path. Keep doing what you are doing. You're doing great. Do not worry about the weight. You are going to achieve your goals in a very healthy manner. Now, what would you do in this patient? She is on 5 milligrams. This is week 6, okay? What would be the most appropriate next step? Would you maintain the current dose indefinitely? Are you okay for her to achieve this 85 kilograms? Would you continue the dose escalation per tolerability? Or would you stop escalation because of the GI symptoms? Or you only focus exclusively on the lifestyle at this stage? So what I did with this patient, actually, since she had, just go back, she had mild nausea and early satiety, I usually coordinate my care with the dietitian, with the clinical dietitian. And I always make sure that my patients are getting enough calories in and they're getting enough protein in. And once I do that, I will continue to escalate the dose. So this is what I did. I continued to escalate the dose per patient's tolerability. So the thing is, we have to remember that the early weight loss is a strong predictor of long-term control success. The mild GI effects are expected and generally manageable. Appropriate dose escalation remains essential. So the decision was made to continue gradual increase of 7.5 and then to 10 milligram after that. So in terms of how much total body weight will Miss R lose at 10 months of tirzepatide plus lifestyle, where do you think we have achieved? So I'm asking you, it's like a guessing thing. So 10 months down the road, we have seen that she has lost 8 kilograms on her first follow-up visit. Where do you think she has achieved? She has only remained on 5%. She went about 10 to 15%, or she achieved 20% or 30%. So what I see, majority of you are saying B or C, and I'm going to show you what happened. So we are talking about 30% weight loss in this patient. 10 months down the road, she achieved a weight of 65 kilograms. Her BMI was 26. We started with a BMI of 37. We're talking about class 2 obesity. Remember, eating less, moving more is not going to do that. Hemoglobin A1C decreased from 5.7 to 5%. LDL is decreased from 155 to 95 milligram. Triglyceride decreased from 200 to 120. Remember what I have shown you in Surmount 1. Remember the LDL that was reduced. Remember the blood pressure that was reduced. Remember the triglyceride that was reduced in those patients, which are the cardiometabolic risk factors. And this was the 30% weight loss that we have achieved in this patient. So we're not only talking about how much weight she has lost, she has done that. And it's the exercise, it's the diet, it's the tirzepatide. She's doing that. She's continuously following up with the physicians. She's not that one who's taking the medications on her own and just increasing the doses by herself. The key here is really the follow-up in the clinic. The key is the diet. The key is the exercise and the communication with the physician. continuously. So if you look at this is where we actually achieve the metabolic outcomes. This is me as an endocrinologist, and you as a physician will be extremely happy by achieving a 30% weight loss, by achieving a BMI that was unthinkable in this patient, by achieving a great numbers we can see on the lab in terms of hemoglobin, A1C, LDL, triglyceride. But you know what Miss R cares about? She really came to my clinic. She wanted to lose weight because she has knee pain. What we found 10 months down the road, complete resolution of her bilateral knee pain, improved in her mobility, improved in her confidence, improved in her occupational performance, and you know what? Subsequently, promoted with her company. So this is where I'm saying, like, thinking about managing obesity beyond the weight loss. This is what we have achieved with this patient. So looking at the final results, what would you consider the most meaningful treatment outcome? Is it really the 30% weight loss? Is it the improvement in lipid profile? Is it the normalization in A1C? No, it's really all of them. But for me and for the patient is the resolution of the knee pain and improved work performance and getting promoted at her work. So I think all of those were achieved in this patient. And really, this is where it's the chance really to step back and think about, managing obesity is not only about looking at the percentage of weight loss. We have achieved that, alhamdulillah. We have achieved a great reduction in her A1C, the LDL, the triglyceride, as well as the weight. Like, what really mattered for this patient is her occupation. So, alhamdulillah. So do we have a lot like Miss R patients? Like, let's talk about Manar, who really wants to achieve that kind of weight loss. We do see a lot of our patients who are living with obesity without type 2 diabetes. صح? They have tried multiple times to lose weight. They've tried multiple times to lose weight. Really, most of the time, might lose a little bit of weight, but they are not able to continue or to maintain what they have lost. And those patients usually, apart from the obesity, they are always thinking about these complications because they have seen their siblings, their parents, their friends suffering from different complications which are related to the obesity and diabetes. And they know what's the burden of the disease of this. And when I say why it's difficult to lose weight only with lifestyle modification, because when patients try to lose weight by their own only by doing diet and exercise, there are some hormonal signals that can be released from the adipose tissue, stomach and intestine and pancreas. Basically, they are affecting the food intake and energy expenditure. This is what we call in our world of obesity a metabolic adaptation. So an adaptive biological response happens to the weight reduction. So basically, when anyone tries to lose weight, there will be some sort of metabolic adaptation that can lead to hormonal changes, as you can see down the screen. These hormonal changes will make the patients regain the weight back. As you can see here, on the left side, before they lose weight, the patients will do the diet, the exercise, they go on extreme diet plans. After they lose weight, what will happen? There will be some sort of energy gap. Their energy expenditure is going to go down. Their hunger is going to go up and satiety is going to go down. What's the result down the road? The result that the energy gap, they will going to regain the whole weight back. They're going to regain the whole weight back. And this is the most common thing I do see in my clinic. Alhamdulillah, the patients are trying to do the lifestyle in terms of their, at least willing to lose weight. But what they are seeing, and we are seeing in our clinic, is the weight regain that can happen after they lose weight. So in this study, and I think there's a question on the screen which was answered by this study, Surmount 4. They investigated, including 780 patients with a BMI of more than 30 or more than 27 with at least obesity-related complication. And the primary endpoint was basically looking at percentage of change in body weight from the time of randomization to week 36, which is okay, which was seen in SURMOUNT-1. ولكن what's very interesting in this SURMOUNT-4 studies is actually looking at change in body weight from week 36 to week 88. So look at what happened at week 36. At week 36, they randomized the patient after they achieved the weight loss. I'm going to show you in the next slide. After they achieved the weight loss, they randomized the patient either to continue the tirzepatide 10 or 15 milligram weekly or to go into placebo. And they continued to follow those patients for up to 88 weeks. So the question I have, there will be a rebound weight gain after stopping the medication. Let's see if we can answer this based on this study. So in this study, SURMOUNT-4, the weight reduction you can see, which is expected, we have seen it in SURMOUNT-1, we are talking about 20% of weight loss. So there were 22, 23% we have achieved in SURMOUNT-1. So at week of 36, we achieved 20.9% weight loss in patients who were on tirzepatide maximum tolerated dose from week 0 to week 36. What happened here? They were randomized either to continue tirzepatide 10 or 15 milligram versus switching them to placebo. So they were randomized to switch them to placebo. Look at what happened to those patients who were switched to placebo. And keep in mind that those patients continued the lifestyle modification with dietitian and educator and exercise program. Because this is the most common thing you can get in the clinic, that doctor, I want to stop the medication after I achieve the weight that I can, and I'm going to continue my lifestyle. Show them this slide. They can continue the lifestyle. Like, what happened with those patients when they were switched to the placebo? 14.8% weight regain. While those who continued the tirzepatide, they actually continued to lose weight from 20 to 26%. So there was a difference of around, you can say 14 plus 8 and minus 6.7. So 9.5% weight regain in those patients actually who were randomized to placebo. What we have seen in SURMOUNT-1 and SURMOUNT-4, not only improvement in weight, as I've shown earlier, also improvement in cardiometabolic profiles, which were actually echoed in SURMOUNT-4, which is the blood pressure, systolic, diastolic, the LDL, the triglyceride, and so on. Again, the tirzepatide will have the similar safety profile to other incretin-based therapies, and no new safety signals were identified in 193 weeks follow-up. We have 193 weeks follow-up. We're talking about more than almost reaching 4 years. Same side effects, which is GI in nature, adverse reactions, which can happen during the dose escalation. So this is, again, the adverse reactions that were reported in SURMOUNT-4 trial, nausea, diarrhea, constipation, vomiting, so on, which is the most common adverse reaction with GI tract nature. Now, let's switch gears and talk about SURMOUNT-5. What is SURMOUNT-5? SURMOUNT-5 is basically a 72 weeks phase 3 trials where patients actually were randomized to tirzepatide, maximum tolerated dose, or semaglutide, which is not semaglutide that was for obesity, semaglutide for diabetes, the semaglutide for obesity, اللي هو maximum tolerated dose of 1.7 or 2.4 milligram. And what they were trying to look at, they were planning to look at the percentage of change in body weight from baseline to 72 weeks. And they also had secondary endpoints. So it was a 72 weeks, phase 3, multi-center, randomized, open-label, comparator controlled, that evaluated the efficacy and safety of tirzepatide 15 milligram, or the maximum tolerated dose, which is 10 or 15, compared with semaglutide 2.4, or the maximum tolerated dose 1.7 or 2.4 in 750 adults with obesity, with at least either they have a BMI of more than 30 or the BMI of more than 7 with obesity-related complication. Interestingly, what we have seen here that at 72 weeks, the participants who were taking the tirzepatide maximum tolerated dose of 10 or 15 milligram experienced a mean percentage body weight reduction of 21% versus 15%. 21% versus 15.4% in those who were taking the maximum tolerated dose of semaglutide, which is 1.7 or 2.4. So you can see the separation of the curve that's happening actually beginning at week 4. And you can see that the percentage of weight loss that actually when those patients were randomized on maximum tolerated dose, but about 21.6% versus 15% on semaglutide maximum tolerated dose. Continuing that, and if we really want to look at the percentage of patients achieving, remember I did that in Surpass, percentages of patients achieving more than 25% of weight loss, more than 15%, more than 20% of weight loss, or 10%. So what you see here, it's very clear that in all these different categories, the tirzepatide did better. Our population on tirzepatide were actually more likely to achieve that percentage of weight loss versus the semaglutide maximum tolerated dose. So you can see that at least 1 in 3, those who were randomized to tirzepatide were able to achieve a 36%, were able to achieve more than 25% of weight loss versus only 1 in 5 for those who were on semaglutide. So only 19% on semaglutide achieved a 25% weight loss versus 36% in tirzepatide arm. And you can see this across the screen for different of those weight categories. The other thing also, which is the waist circumference, and I strongly advise if you're seeing patients with obesity, really to ask your patients to do the waist circumference measurement. You can do it in the clinic, but our patients are much better than us. They can do the measurements not only of waist, they can do the hip ratio, they can do the arms, they can do the thighs. But over here, focusing on waist circumference in those who were randomized to tirzepatide versus the semaglutide, you can see 20 centimeter in those who are on tirzepatide versus 14.7 centimeters. So participants taking tirzepatide maximum tolerated dose experience a 20 centimeter reduction in waist circumference. So for the adverse reactions, they were comparable in terms of the GI upset, and they were comparable even in between both treatment groups, either the semaglutide or tirzepatide. You can see the nausea approaching up to 43 and 44%, the constipation 27 versus 28%. So they were completely almost presenting or behaving in similar way in terms of the adverse reactions. So what have SURMOUNT-5 showed us? That's comparing the tirzepatide maximum tolerated dose versus the semaglutide, that it has shown a superior reduction in body weight with a superior percentage of patients achieving a weight reduction targets. Remember those categories I showed you, the 25%, the 10%, the 15%, and also superior reduction in waist circumference. Let's switch gears a little bit and talk about a patient instead of just presenting the data. So this is Mrs. X. She's 42 years old, female. She does have class 2 obesity with a long-standing history of unsuccessful weight management. She presents to my clinic. Her weight was 82. Her BMI was 38, so class 2 obesity. Her A1C was 5.6%. Her fasting glucose was 105. LDL was 135. Creatinine of 0.8. ALT 31 and AST 28. And as I explained earlier with the slide of metabolic adaptation, remember that slide with this patient, despite consistent lifestyle efforts, including structured exercise program, she reported cycles of weight loss, 5 to 7 kilograms over the 3 months. What happens? Rapid weight regain upon resumption of normal eating patterns. So I think we really have to stop blaming our patient. It's not easy. It's very challenging when we do see patient with obesity joining the gym, going to exercise 3 to 4 times a week, and we are blaming them that they are not doing enough. They are doing enough, but the biology is acting against them. The next slide, I explained to you what the metabolic adaptation is happening in those patients. So I think most of you know the answers this. Despite the structured exercise program, Mrs. X keeps losing then regaining. What's best explain this? Is it that she does not have willpower? She does have insufficient willpower. She does not exercise enough. Maybe she needs to go 6 days a week instead of 3 days a week. She might have hidden dietary non-adherence. ممكن نسألها انت ايش بتحط في السرير? What are you doing? What's, you know, maybe you're eating at the end of the night, and start blaming their diet. Or is it the metabolic adaptation that's happening? So look like majority of you are going with B. Yes, this is a metabolic adaptation that actually defending the fat mass. Obesity, as I told you, is a chronic disease, chronic relapsing multifactorial disease. And when patients try to lose weight, their body energy expenditure goes down and the appetite signal goes up to defend this, driving the regain regardless of the patient effort. So really B is the answer, is the metabolic adaptation why she's not able to lose weight. Now, she comes to my clinic, she has obesity, she has early metabolic risk, as you can see, as I've shown you her labs. What is the most appropriate next step? Should I just tell her to continue lifestyle alone, reassess later? Should I start the triglyceride along the lifestyle? Should I refer her to the bariatric surgery? Should I start metformin for prevention? What should I do? So of course, you know, we are going to start tirzepatide for weight prevention. This is what was done. We have figured out a patient who's suffering and struggling with obesity, who is really doing good in terms of her lifestyle. She's going to the gym 3 to 4 times a week. She's willing to follow with the clinical dietitian. She does have, despite doing this, she does have an early metabolic risk. Her HbA1c was around 0.6%. And she's an appropriate candidate for pharmacotherapy. So we initiated the tirzepatide. And of course, like I did with my previous patient, we started 2.5 milligram for 4 weeks, escalate the dose to 5 milligram, escalate the dose to 7.5 milligram, third month. What's the outcome we have achieved? In this case, I'm not going to show you the outcome only in terms of the weight loss, in terms of the kilograms. Over here, I'm going to show you the actual outcome in terms of the in-body numbers. So yes, we're able to achieve a weight loss from 82 to 65 kilograms down the road. We are talking about at least 10 to 12 months, or I think 8 to 10 months. Look at her fat mass. The fat mass was reduced significantly from 51 to 42. She still has a way to go. Expected, the skeletal muscle mass was decreased, but this was slightly decreased. So early weight loss was predominantly driven by the fat mass reduction. And this answers one of the questions I saw in the chat box, that is it okay to lose the weight that quickly? So that early weight loss, you can see, mostly was driven by fat. And you expect to see a little bit of lean mass loss. This is why we see patients in the clinic. No, this is why we follow up with them. This is why they need to see the clinical dietitian. So what we did is, since she has lost a very good percentage of her weight, she has achieved what she wanted, we can try to continue the same dose of tirzepatide. I think 10 milligram, this is what we continue. Down the road, she achieved further weight loss of achieving 60. So remember, we started with 82, and then we achieved 60. So we are talking about 22 kilograms of weight. So we're talking about almost 30% of weight loss. What we noticed that when she reached 60, that The skeletal muscle mass was preserved when I was following up with her in body. She continued to lose the fat with stabilization of lean mass. Let's look at her numbers. So follow up 55 kilograms, it started at 82. So this is where she achieved 55 kilograms. Skeletal muscle mass is at 21 kilograms. It started at 32. Yes, I agree. She lost significant, like she's able to maintain and increasing by doing her exercise. The fat mass, look at 51% versus 35% of fat. So we started at 51%. Now she's at 35%. And she's continuing. So this is give us the chance in the clinic to really sit down with the clinic and really talk about this is your chance to do more exercise. This is your chance to improve your protein intake. It's not about the medication anymore. It's about that you are living a new era and we are treating your obesity. And this is your chance to improve this further. And lastly, and we are so lucky and excited that we've received the Saudi FDA label for treating obstructive sleep apnea with obesity using tirzepatide. So what is the obstructive sleep apnea? It is one of the most common sleep disorders. We're talking about 420 million people are living with moderate to severe obstructive sleep apnea. And it develops because of the upper airway obstruction during sleep, which can lead to severely reduced or absent airflows because of the hypoapnea or apnea. What is it characterized by? Characterized by upper airway collapse during the sleep, insufficient breathing, sporadic low oxygen levels, sleep disturbance. What happens when the patient wakes up? They will have excessive daytime sleepiness, headache, forgetfulness, mood changes, low libido, gastroesophageal reflux disease, restless sleep, insomnia, snoring, and fatigue. And if we look at the percentage of obesity or a BMI, overweight and obesity, BMI of 25 or higher in those patients who have obstructive sleep apnea, we are talking about 60 to 90% of those patients. So 60 to 90% of patients with obstructive sleep apnea will be either overweight or obese. And this is a very high number. And alhamdulillah, now we have a medication, finally, to help those patients to treat, when we treat their obesity to improve their obstructive sleep apnea. And if we look at the relationship between the obesity and the obstructive sleep apnea, how does the obesity can contribute to the obstructive sleep apnea? Because of the high adipose tissue can lead to the airway obstruction, deposition of adipose tissue at the anterior neck that can result in a physical obstruction that's already floppy airway during sleep. And patients will experience the apnea or hypoapnea due to the complete or partial collapse of the upper airway. And people living with obesity also will have a reduced lung volume, on the other hand, which can also reduce the airway caliber. Reduce the airway caliber will lead to increased likelihood of airway collapse during the sleep. On the other hand, the obstructive sleep apnea itself has been shown to contribute to the obesity because a fragmented sleep, reduction in the airflow, breathing cessation, recurrent nocturnal arousals, disruption in appetite regulating hormones. What do the patient do when they wake up? And of course, they will have decrease in leptin levels, increase in the ghrelin. Remember those hormones we discussed during the metabolic adaptation? We are seeing them with obstructive sleep apnea. They will have increased the preference for energy density food. You're going to hear patients saying, Doctor, أنا أشخر ما بنام في الليل. I'm not able to sleep well. And when I wake up, I go and eat. So obstructive sleep apnea can be caused by obesity. On the other hand, it can lead to obesity. Obstructive apnea-induced fatigue can lead to reduced physical activity and changes in appetite control mechanism, which can result in the weight regain and make it difficult to lose weight. So they share the same risk factors and might have this bidirectional causal relationship. What happens if patients with obstructive sleep apnea left without treatment? What kind of complications they can develop? I always get this kind of referrals from my dear colleagues of cardiologists. and pulmonologists when they are not able to control their patient's hypertension or heart failure. So 42% of patients living with obesity have hypertension. 20 to 40% of patients with hypertension have sleep apnea. 70% of patients with resistant hypertension that's not being controlled by medication have sleep apnea. Looking at this heart failure, male patients of obstructive sleep apnea are 6 times more likely to be treated for congestive heart failure versus those who do not have obstructive sleep apnea. People with obstructive sleep apnea are 2 times or more likely to develop heart failure than those without obstructive sleep apnea. So having an obstructive sleep apnea is not only leading to obesity or bad quality